Välkommen till Svenska Läkaresällskapets webbmöte om levnadsvanor inför operation. Jag heter Roger Olsson och är projektledare för Svenska Läkaresällskapets arbete med levnadsvanor inför operation. Jag kommer att vara moderator för mötet och med mig har jag co-moderator Katja Stenström-Bohlin som är gynekolog, överläkare vid Sahlgrenska Universitetssjukhuset. Frågor till panelen kan ställas via chatten och Katja kommer att bevaka ställda frågor och ta upp dem vid de tillfällen vi har frågestund. Dagens möte kommer att spelas in på Svenska Läkaresällskapets YouTube-kanal där man kan hitta det senare och man kan också plocka upp det genom att gå in på Svenska Läkaresällskapets kalender med dagens datum 4 december och klicka där om man vill ta del av programmet senare. Okej, ska vi visa programmet? Nästa bild. Så. Vi har ett fullspäckat program. Tidigare möten har vi tagit upp som regel en levnadsvana i sänder, pratat om rökning eller alkohol, övervikt. Vi har också haft uppe prehabilitering. Den här gången fokuserar vi på det som är oavsett vilken levnadsvana, det som vi har ansett vara nyheter senaste året. Jag kan också säga att mötet kommer att ske både på svenska och engelska. Det will be a combined Swedish English speaking meeting. Och till alla skulle jag vilja säga att stanna till den sista delen. Vi har med oss superexperter på det man kallar prehabilitering för kirurgi. Jag kommer med till mer presentationer senare i programmet. Nästa bild. Många känner nog till att det i år finns ett nationellt vårdprogram vid ohälsosamma levnadsvanor vid prevention och behandling. Det här hittar man under nationellkliniskkunskapsstöd.se. Och så klickar man på bokstaven L som är levnadsvanor och går in på vårdprogram. Hela vårdprogrammet är 135 sidor. Det utgår ifrån Socialstyrelsens nationella riktlinjer, men medan riktlinjerna mer beskriver vad man ska göra så har man här tagit upp hur det ska göras. Nästa. 12 sidor i det här programmet handlar om levnadsvanor inför operation. Och det här är någonting som angår patientsäkerheten inför operation. Man kan allmänt säga att utvecklingen har gått på senaste 25 åren mot en mycket säkrare kirurgi med framförallt mindre traumatiska metoder och anestesiologiska metoder som har inneburit snabbare mobilisering och snabbare återhämtning. Första idéer kommer ifrån Kelet, Danmark i slutet på 1990-talet och hela perioperativa omhändertagandet har skett enligt det som är ERAs koncept, Enhanced Recovery After Surgery. Och vid tidigare möte hade vi Olle Ljungqvist som tidigare var internationell president som är professor i kirurgi som föredrog hur ERAS-programmet är upplagt. Levnadsvanor inför operation har vi känt till under lång tid att det kan bidra till ökade komplikationsrisker. Komplikationsrisker av rökning är känt att det ökar risken ända sedan tiden för andra världskriget. Men studier som visade att redan kortare tids intervention med rökstopp, alkoholstopp kunde påverka komplikationsrisken kom inte förrän omkring 2000 och implementering i större skala har egentligen inte skett förrän under senaste 10-årsperiod. Det här handlar alltså om att optimera patientens förutsättningar för säker kirurgi. Och i programmet så finns 4 delar. Rökning, alkohol är en fortsättning på det som är Socialstyrelsens nationella riktlinjer. Medan det egentligen inte har funnits några sådana för fysisk aktivitet och nutrition. Men det finns ändå med i det här programmet. Jag kan inte redogöra för hela det, det är ändå för omfattande, men jag kommer att ta upp några punkter för att illustrera vad programmet innehåller. Nästa. Varje stycke som rökning har en bakgrundsbeskrivning, men annars är varje stycke upp efter de här rubrikerna hur man uppmärksammar och åtgärdar och följer upp. Ja, hur man uppmärksammar berör ju att man bör fråga patienten om levnadsvanor och inför operation och beskriva vilka komplikationsriskerna är och hur en intervention kan minska riskerna. Så att säga, så att man kan komma till ett gemensamt beslut så att patienten är väl motiverad. Nästa. Ja. Åtgärder vid rökning. Den rekommendation som är inför elektiv operation är rökstopp från minst 4 till helst 8 veckor före operation och lika lång tid efter. Och rekommenderad åtgärd i första hand kvalificerat rådgivande samtal med erbjudande och tillägg med nikotinläkemedel. Jag tror alla känner igen det här. Nästa. Ja, vid riskbruk av alkohol så är förstahandsrekommendationen rådgivande samtal. Men alla kan rekommenderas alkoholuppehåll 4 veckor före och en tid efter operation och till sårläkning och gott allmäntillstånd uppnåtts efter operation. Det senare bygger egentligen på en god klinisk praxis och det förstnämnda på den evidens som finns på området. Vid riskbruk av alkohol med utvecklat beroende, en punkt som är tillagd och som inte finns med i Socialstyrelsens nationella riktlinjer, rekommenderas kvalificerat rådgivande samtal med eventuellt tillägg av alkoholläkemedel. Nästa. Här går vi alltså utanför det som är Socialstyrelsens riktlinjer och har ändå tittat på det som finns i litteraturen beskrivet. Och något som alla känner till är förstås att låg fysisk prestationsförmåga ökar risken för postoperativa komplikationer, ger längre vårdtid och längre tid för återhämtning. En studie av Snowden på leverkirurgi där man hade testat maximal syreupptagningsförmåga och syreupptagningsförmåga vid det man kallar anaerobic threshold visade att den gruppen med sämst prestationsförmåga hade ökad dödlighet, och om man tog hänsyn till de här testerna så var ökad hög ålder inte längre en separat enskild riskfaktor. Och förstås har det här lett till att man tänker sig att fysisk träning inför operation skulle vara gynnsamt. Och enstaka studier med fysioterapeutledd högintensiv träning före bukkirurgi har varit framgångsrikt. Men andra studier har inte visat någon förbättring. Och frågorna har då varit, har man haft för kort tid tillgänglig? Har intensiteten varit för låg eller har man inte tränat tillräckligt ofta? Ta nästa. Hur ska man bör ändå uppmärksamma fysisk aktivitet, och det finns screeningfrågor för fysisk aktivitet, så det kan man ju mäta aktivitetsminuter per vecka. Angående fysisk prestationsförmåga så kan man gärna använda Svensk förening för anestesi och intensivvårds digitala hälsodeklaration. Den finns upptagen och beskriven hur man gör i vårdprogrammet. Och exempel på en sån fråga: jag klarar tyngre hushållsarbete som att svabba golv, dammsuga, gå upp för en trappa. Alltså ett sätt att anamnestiskt värdera fysisk prestationsförmåga. Nästa. Ja, vid skör patient inför stor kirurgi så behöver man erbjuda stöd till optimering. Och viktigt är förstås att identifiera de här patienterna som riskpatienter inför kirurgi. Och till läsaren så är det ju så här att vi påpekar att evidensen är under snabb utveckling. Det här är ett område som man bör följa nära. Och det är också så att här finns specialitets- och klinikspecifika rekommendationer som man får titta efter. Nästa. I programmet så pratar man ju om matvanor och nutrition. Här skriver vi nutrition och nutritionsstatus eftersom det är det som bäst beskriver den grupp som vid intervention kan få minskad risk för komplikation vid operation. Undernäring fetma medför ökad risk och risken är större vid mer omfattande kirurgi. Stor kirurgi, thorax-bukkirurgi medför ett metaboliskt cirkulatoriskt påslag som ökar ämnesomsättningen 50% eller mer och ökar behovet av energi, proteiner och näringsämnen på grund av den kirurgiska stressen. Ett område som man kan inhämta mycket kunskap är till exempel ESPEN Guidelines, Clinical Nutrition in Surgery. Man kan titta på de olika ERAS-programmen och här finns också beskrivning på Dietisternas riksförbunds sida. Nästa. Hur uppmärksamma? Ofrivillig viktminskning är alltid en riskfaktor. En allvarlig risk föreligger särskilt vid snabb viktminskning som 10-15% senaste 6 månader. Vid lågt BMI, mindre än 18,5 och vid lågt serumalbumin, mindre än 30 gram per liter. Och kanske allra bäst är enligt bedömning med något av de validerade screeninginstrument som finns och är i bruk. Nästa. Och vid undernäring eller risk för undernäring bör bedömning kostbehandling utföras av dietist. Men ibland är det särskilt bråttom och man kan förstå att dietister kan vara långt bort beroende på var man nu befinner sig. Och så att om det kan ske utan rimlig fördröjning så gör man det här av dietist, men annars efter samråd med eller riktlinjer från dietist. Vid undernäring har nutritionsbehandling under så kort tid som 7-10 dagar framgångsrikt används för att minska komplikationsrisker. Nästa. Okej. Ja, det var en snabb genomgång av det nationella vårdprogrammet, men ta gärna del och läs igenom de 12 sidorna. Nu ska jag släppa in Noes Lydom och hennes kollega Sofie Skovbo Jensen från Danmark som har gjort en intressant litteraturstudie. Varsågod Line.
Thank you very much. Thank you. My name is Line, and I'm here together with Sofie. We are both PhD students of Professor Hanne Tønnesson's. We are presenting our joint work, a systematic review with the title Impact on Postoperative Complications of Combined Prehabilitation, Targeting Coexisting Smoking, Malnutrition, Obesity, Alcohol Drinking, and Physical Activity. The review has been submitted and is undergoing review. And we want to thank the Swedish Läkaresällskapet for inviting us to present here today. So I'm going to talk a bit about the background of our study and the aims and methods, and then Sofie is going to come and tell you something about our results and the conclusion of our study. So as you probably know, surgery is the gold standard treatment for numerous diseases and conditions, and all surgical procedures are to some extent related to a risk of postoperative complications. And the consequences of complications include reduced quality of life and life expectancy and prolonged recovery for the patient, as well as increased healthcare costs. Much attention has been put on improvements within perioperative care, such as improved surgical and anesthesiological techniques, and the implementation of enhanced recovery after surgery. However, there seems to be an increased attention for the investigation of the effect of interventions in the preoperative phase. A part of the postoperative morbidity is related to what we can call patient-related modifiable risk factors, such as smoking, nutrition, both malnutrition and overweight or obesity, risky alcohol drinking, and physical inactivity, as we just heard Roger tell us about. We also call this the SNAP risk factors. These factors all contribute to an increased risk of complications at surgery. Daily smoking, risky alcohol intake, and severe malnutrition are followed by a 50% increased complication rate, whereas overweight or obesity and low physical activity are associated with complications to a minor degree. Up to 50% of hospitalized patients have coexisting risky lifestyle factors. The good news is that we do have an opportunity to mitigate this increased risk associated with the SNAP factors by offering prehabilitation, meaning interventions aimed at enhancing the functional capacity of the patient by preparing them to withstand the stress of surgery. The SNAP factors are modifiable by prehabilitation, but the impact on the postoperative morbidity differs among the SNAP factors. And only the most intensive programs targeting smoking and alcohol and malnutrition are followed by up to halving of the complication rate. Whereas research has shown that exercise interventions in the preoperative phase can enhance physical fitness, however, clear impact on the postoperative morbidity still remains to be seen. And the effect of overweight or obesity interventions have only poorly been investigated outside bariatric surgery. Until now, most of the evidence from SNAP intervention is based on investigating one risky SNAP factor at a time, for example, the effect of a physical training program. However, we do see an increased attention for the need to offer multiple interventions as part of a prehabilitation program. So this led us to the aim of our study, which was to evaluate the effect on postoperative complications of perioperative interventions initiated prior to surgery and targeting predefined coexisting risky SNAP factors compared to treatment as usual in adult patients undergoing surgery. And by predefined, we mean that the risky lifestyle factors should be an inclusion criteria for the study. So we conducted a systematic review. We followed the instructions in the Cochrane handbook and followed the PRISMA guidelines. And we did a very extensive literature search in 5 major databases. We searched for randomized controlled trials with populations of adult surgical patients with at least 2 predefined risky lifestyles who were allocated to combined risky lifestyle intervention or treatment as usual in the preoperative phase. And we only included studies that had postoperative complications as an outcome.
So now we get to the results. As Lena said, we did a very large screening on title and abstract of almost 21,000 records. Unfortunately and surprisingly, we were only able to include 2 studies in the review. Of the excluded reports, I would like to highlight 22 studies who actually fulfilled almost all of our inclusion criteria, except for the criteria of having predefined risk factors. but we'll get back to those 22 later. So first, I'll go through the 2 studies that we were actually able to include. One was by the Carly group from Canada, investigating colorectal cancer patients with a population of 110 patients. They were included based on having a Freed's Frailty Scale score of at least 2. The Carly group investigated intervention of combined physical exercise, nutritional intervention, and a very brief smoking and alcohol cessation intervention. They received a total of 40 days of prehabilitation. The second study we included was by Lauritsen from Denmark, who investigated bladder cancer patients receiving radical cystectomy. In their study, a subgroup of only 10 patients were daily smokers and had a risky alcohol intake. They were allocated to either an intensive smoking and alcohol cessation intervention or treatment as usual, but the prehabilitations were only for 8 days before surgery. So we were only able to include 2 studies with very few patients. We did a meta-analysis on postoperative complications that showed no significant difference. For all of our many secondary outcomes, we didn't find any statistical significant difference either. But then we had the 22 studies that we could almost include. They were all investigating multiple SNAP interventions, but they were not aiming at multiple predefined risky SNAP factors. Of the 22 studies, 16 investigated a combined physical exercise and nutritional intervention. So that was by far the most popular prehabilitation combination. Furthermore, 2 studies investigated combined alcohol and smoking cessation intervention, physical exercise and nutritional intervention. 2 studies investigated smoking cessation, physical exercise and nutritional intervention. 1 study investigated smoking cessation, alcohol cessation, and physical exercise intervention. And at last, 1 study investigated a combined intervention of smoking cessation and physical exercise. Another way to look at the 22 studies were that 6 of them included 1 predefined risk factor in the populations, while the remaining 16 studies didn't have any predefined risk factors, and therefore they offered prehabilitation to patients with no regards to whether they were actually unhealthy or not. So, in conclusion, we believe that prehabilitation of combined risky SNAP factors does have a potential for improving postoperative complications and probably health on longer term. We found that many prehabilitation studies on multiple interventions have been performed, but only few actually included pre-identified risky SNAP factors. So in the future, we need to consider the patient's actual need for risk reduction when offering prehabilitation, instead of offering it to everybody with no regards of need. Thank you for listening. That's all we have today. So, Olga, I think you're still on mute.
Okay, thank you. Sorry, I was muted. Katja, do we have any questions from the chat?
No, no questions.
Okay.
At the moment.
I have read those studies available concerning smoking cessation and alcohol cessation, and I have often wondered, what about when you combine these interventions? No wonder that I have almost found nothing. Okay, thank you. Do we have Hanne Tönnesson with us?
No, she is actually not here yet.
Okay. In that case, I just wonder if we could change a bit in the program then. And if you are prepared, Sandy Jack, Sandy is a professor of prehabilitation at the University of Southampton, and you have contributed to our knowledge earlier times, and I welcome you very much. Okay. You're going to speak about prehabilitation before surgery, Anderson, please, Sandy.
Thank you very much for that kind introduction, and it's my pleasure to be back here talking about prehabilitation before surgery. So over the last 55 years, there's been an explosion of interest in prehabilitation, and the literature supports this. So you would think after 55 years of work in this area up to date, with a lot of trials that were started before COVID, the large randomized control trials that were going to be actually effectiveness trials would give us the answers. However, sadly, lots of the trials, including ours, was paused during COVID, and we then went on to make the decision whether we should restart the trial or not, which I'll talk about in the later slides. So, however, we have so many known unknowns and unknown unknowns that we're now back almost to the drawing board, as we say in Britain, that we need to rethink multimodal prehabilitation and the pillars of prehab, which are exercise, nutrition, emotional, psychological support, wrapped around with behaviour change. I think from the excellent presentation I've just heard, that in all our reports around prehabilitation, it's standard care to do all of the lifestyle changes. So part of our perioperative medicine and going into ERAS, then that's standard of care. So perhaps that's why it's not included in the trial, but it should be standard of care for all patients prior to surgery. And I think this is why we're trying to delineate between these two, because otherwise you're trying to get funding for a prehab service, which is more complex and more costly, whereas the basics that you've talked about are so important in improving surgical outcome. So the explosion of all of these literature, I just want to cover the most pertinent points. It's working. So when we all started this, and I started this 15 years ago, we thought it was all about exercise, but actually we realized very early on, you can't put out what you don't put in. So nutrition is key. And actually you want to do the right kind of exercise so that patients don't lose lean muscle mass, which is quite challenging. Moreover, probably the most important study is from our friends and colleagues in Australia, in Canada, showing that in the systematic review and meta-analysis, that prehabilitation with or without exercise still improved outcome with 2 days length of stay. There may not be an effect on complications, but this is actually quite a complex construct. And length of stay seems to be the outcome that we all concentrate on. Is it the right outcome or not? Well, probably not in our health service, because sometimes it's whether it's on payment by results, which would be return on investment, or it's actually just tariff. So does it matter or not? And the jury's still well and truly out about, we know aerobic training improves outcomes, physical fitness, and also has been shown to improve complication rates, length of stay, morbidity and mortality. But what about resistance? It's counterintuitive not to include resistance, but there's hardly any time within the surgical pathway of, on average in our studies, our more pragmatic studies, of only 2.5 to 3 weeks. So we really need to concentrate on good bang for buck, but the trials need to be performed to look at resistance training and measure lean body muscle mass actually as the outcome, rather than it being cardiopulmonary exercise testing, functional capacity, which may not increase and improve when it's resistance training alone. So I just thought I'd highlight this excellent research priorities in prehab that's going to derive and deliver and support the process of the hot topic of prehab in many many efforts to try to relook at the Macmillan, NIHR, Royal College of Anaesthetists guidance, which will be guidelines, and some Delphi processes that are also occurring. So optimal exercise modality, effect of prehab on surgical outcomes, which surgical outcomes, what's important to patient, what's important to health services and the funders, identify populations that benefit most. What about this responder or non-responder? Nutrition is key, and we still really don't understand how we can integrate this with this complex intervention of multimodal prehab. Cost effectiveness and health economics are hardly ever performed within the literature. Modes of delivery of prehab, defining core outcomes are really important. Again, what's important to the patient, psychological interventions and medical optimization, enhancing compliance and adherence. And the list continues to go on, looking at patient education and prehab during neoadjuvant therapies, also patient-reported outcomes and the optimal duration of prehab programs. And most importantly, for me, wearables in prehabilitation, and also not forgetting the mechanistic side of it, biomarkers, response to prehab. So going back to that, the reason why we continue to do our prehab program, including prescribed structured responsive exercise training programs, is because of our data and our evidence. We showed fairly early on that patients undergoing chemotherapy or chemoradiotherapy for colorectal or upper GI cancers actually reduced their physical fitness. And we repeated this in this sub-study, which is in colorectal patients undergoing long course neoadjuvant chemo-rad for advanced rectal cancer surgery. And we saw that the exercise group and the control group fell after neoadjuvant chemo-rad, and the exercise group recovered within 6 weeks. Actually, from our earlier data, there was an increase even within 3 weeks. So because this was all driven by the point at anaerobic threshold, so the point where your efficiency or less efficient energetics come together and supplement one another, we wanted to, it pointed towards this being mitochondrial damage. There'd been some indication about platinum-based chemotherapy causing mitochondrial damage. So we wanted to try and understand this in more detail. So we put our patients in this magnet here, looking at phosphocreatine recovery kinetics, which is basically energetics. And they did maximum voluntary contractions at 60 and 90% of their MVB. And this was recorded in this clever magnet. And what we showed was actually that phosphocreatine recovery kinetics, all driven by mitochondria, were slowed after chemoradiotherapy and then speeded back up during exercise. So the exercise group, again, recovered with mitochondrial function being significantly improved. And we thought then, we then back extrapolated to an animal model, and we saw that platinum-based chemotherapy punches holes in mitochondria, and they are less efficient, and there's less and a reduced number. So it's not surprising patients feel fatigued, and just being able to tell a patient that this is a physiological response, not a psychological or weakness when they feel fatigue, has been a game changer. So we were then concerned about whether we were doing harm, because we then went on to look at doing exercise training, so same HIIT training program, before, during, and after chemotherapy, because we thought we've reversed this. Can we ameliorate it? So we looked at patients, these are the colorectal, rectal cancer patients at week 9, at week 14. So they've had their long course chemo-rad, and now we're waiting at week 9 to week 14 for the local inflammatory processes to reduce, so that the outcomes are better according to the literature. And we showed, looking at tumor regression grade, that actually the exercise group had a favorable outcome of 58% compared to the control group of only 22%. This was exercise versus control, and we went on then to look further into the detail of whether people responded or not. So the minimally clinically important difference of increasing their anaerobic threshold and VO2 peak was a responder, and that made the p-value even stronger and the relationship even stronger. So in fact, we didn't do harm, as suggested early on in the American College of Sports Medicine guidelines in 2007, that stated that if you're sedentary and undergoing cytotoxic treatment, you shouldn't exercise. So we myth busted that one. We then went on to perform a randomized controlled trial called the Empower trial, and this was in colorectal patients. And we showed, because patients then wanted the training program to be extended to 9 weeks, that we showed that again we could reverse the effects of chemoradiotherapy, and the exercise group had a significantly improved physical fitness, and therefore in a lower risk band than the control group, who continued to reduce their physical fitness. This was all performed in hospital, and having listened to many patients and done many of these trials myself, I thought we need to be able to deliver this in a cost-effective manner that's equitable care to all patients. So in my view, it was quite ambitious, but we then wanted to be able to deliver all the interventions, both exercise and psychological support, in a community setting near to patients' homes. And these ended up being the gyms and our leisure industry. We got £2.3 million from our NHS England Cancer Transformation Fund to deliver WestFit, which is a factorial design, pragmatic randomized controlled trial investigating the effects of multimodal prehab in all patients undergoing elective major intracavity surgery. So that was open and running by 2018. And then unfortunately, we had to pause WestFit in March 2020, when all the gyms closed. It was really devastating because we had to tell 9 patients on the trial that we could no longer support them at the time that they knew surgery was going to be cancelled. And there are many patients that have been so lonely and self-isolating that they really appreciated even a conversation over the phone at that point. So it was within 2 weeks, I thought, I need to do something about this. And I managed to get some pump priming funding from Macmillan Cancer Support. And we put together our SafeFit trial, which translated everything we were doing in WestFit in a more universal, so lower dose, but delivering interventions as a virtual manner to support psychological and physical well-being in patients with cancer. And it was a protocol of a COVID priority trial, non-randomized, in patients with a cancer diagnosis or suspicion. So for SafeFit, we had 1,100 patients. It was powered to 1,100 patients, national trial, and we actually have delivered this early and we're in follow-up. I can't really share the results with you other than it was the most rewarding and challenging time in the whole of my clinical academic career, but the most rewarding, with patients saying that we saved their lives, etc., etc. What's really important, and I think because this would be a hybrid approach, is that we had no serious adverse events that were attributable to the interventions. Now, we were pretty blind at the time because we didn't have any clinical feedback, so we had to do really robust screening and assessment. And then the interventions were delivered by the CAN rehab instructors who were qualified in cardiac and respiratory conditions, as well as metastatic disease, etc. And also we had 91% adherence to our interventions. So WestFit. Well, WestFit, we then looked at an interim analysis fairly recently, and we have decided that we are not going to reopen WestFit for ethical reasons. So we've stopped at 350 patients. We had 6 hospitals, and our primary outcome, just to remind everybody, was the difference between group 1, which was control and standard care, exercise, which was delivered on programmable bikes within community gyms using the same training program as we had on our other trials. So it's structured, responsive, HIIT training, psychological support in wellbeing centres, and the combination of exercise and psych support in wellbeing centres and gyms, all delivered by the third sector, so exercise instructors, and counsellors and psychologists within the health and wellbeing centres. It was powered at 1 day length stay difference between group 1 and group 4. I can't go into too much detail, but you may get hints along the way when I talk about how we've rapidly translated WestFit into a service. So it's worth saying also that the international prehab trial from our friends and colleagues in the Netherlands actually is an underpowered but positive trial showing that a reduction in complications of all complications, severe complications, medical complications, surgical complications, and both, without an increase in 6-minute walk distance and other physiological and functional capacity outcomes. So although underpowered, this is a positive trial. And this is the message I think that we're going to have throughout. So what about translating this into a service? So perioperative medicine exists, and this top layer here, risk assessment, comorbidity, optimization, which is lifestyle, and surgery, and enhanced recovery all exists within our service. So we integrated the pillars of prehab within this service and shared decision making, and it still took us 6 months to set this internal pilot up. We had 100K from our Wessex Cancer Alliance, and there was some underspend from SafeFit because we finished early and we had some staff resource. And we ended up doing 500 patients. We based it on only colorectal and upper GI neurology in the first instance, with predominantly male, but that's because it was heavily colorectal, because we have a very invested colorectal surgeon who is the West on all our publications, as in Malcolm West. We did digital screening. This is a screening tool that we use through our health system, health information system, that we then assess patients, and then prehab interventions were intervention and needs-based interventions of digital, universal, targeted, and specialist. It's based on this, which I'll go through in more detail on the next slide. And this then led us to put together our business case to our trust investment group to fund a substantive service for 500 to 1,000 patients a year at a cost of 330K. So what we really said and stated was that you should stage the patient, stage the tumour, you should bring all the pre-op assessment further forward, it should be delivered with MDT and shared decision-making. All of this should happen within the service for perioperative medicine. If you then triage patients according to their risk assessment of green being low, intermediate being amber, and high being red, then elective hubs for pre-assessment, and potentially this could be online surgical school rather than surgery school rather than being face-to-face. If they're high risk, they go to a high-risk shared decision-making clinic. Low-risk patients, the minimal they have at Universal is a gym membership and then supported self-management, apps, and signposting to community. If any patient then screens that they are intermediate risk, then we actually do the risk assessments of cardiopulmonary exercise test, dietetic assessment, etc. And then we deliver the interventions in accordance to their needs-based. So community-based, supervised, dietetic counselling. We start oral nutrition supplementation if there's any concerns about weight loss and unexplained weight loss and reduction in BMI. And then psychological counselling at level 1 and 2. Exercise is just different because we do supervised exercise sessions, and the rest is really standard care at specialised. This is how we run our service, so from consultant referral, and this is for your information. I'm very happy to share. What we did know and realised was that, so 197 patients completed screening, specialities I've already mentioned, but red and amber was 37.8%, nutrition 72%, and 41% for emotional. The reason why some of our universal support was so high is that the patients didn't have time or couldn't get to a local gym. So we actually did this as a prescribed home-based training program. We found out actually that perhaps you need to break down targeted, because some of the patients were low targeted, but we didn't feel they were safe to go and sit on a bike in a gym on their own because they were frail, or we had concerns about safety. So did we get our business case funded? So our internal pilot showed 2 days reduction in length of stay, which may or may not be consistent with our research, should I say, in accordance to Westfit. And altogether, we saw a cost saving of £729 of all of the benefits you would imagine would count. However, we then hit a brick wall, as we say, because they said they're not tangible, real cost saving. So we only got our business case funded because we did our pilot service. And we looked at all the patients on our pilot service, and no patient was cancelled on day of surgery. And that's how we managed to get our business case funded. The really good news in the UK, and I think this will roll out across the whole of Europe, is that it's now being mandated from March 2024. There should be early screening and risk assessment. If patients fail the screening and there's concerns about risk assessment and they are deemed high risk, it's shared decision-making with the MDT and the patient's family. Only when they've received health optimization and we realise that they have then improved their risk assessment level and they are safe to go to surgery will we put them on the so-called waiting list. So these are going to be a preparation list leading to a waiting list, and we will not put patients on a waiting list until they are optimized. We need a bank of patients that are fit so that if there are cancellations on day of surgery, which happens so often in our services, that we can then go to those patients. There's also a major condition strategy. Patients with cancer have major conditions, and patients with major conditions also have cancer. And this is one of the priorities. We also were very successful in our NIHR Southampton Biomedical Research bid within perioperative and critical care theme, which is funded alone for the first time in only our hospital in Southampton and in London, UCL. That it was all underpinned by resilience, and we actually have a prehab and rehab theme that I am the lead for. In summary, there's a lack of evidence for effectiveness of multimodal prehab. Exercise is still the strongest. There's strong evidence perioperative nutrition, but it's emerging evidence for multimodal and also psychological support and behaviour change. There's an urgent need for core outcome data set. We really need to understand screening and assessment tools better. We're revisiting the guidelines, and we will then, the guidance, and these will be guidelines. And we strongly recommend, and this is a consensus, there is a generic screening tool for all the pillars of prehab rather than trying to mix up screening and assessment tools. There remains heterogeneity of patient populations and poor description of the type and timing of interventions delivered. We're revisiting the guidelines, so these will be released in autumn 2024 at the World Prehab Congress in Australia. And there's 2 Delphi processes looking at screening assessment tools and reporting interventions across UK and Canada. Thank you so much for your attention. I'm happy to take any questions, and there are my contact details.
Okay, thank you very much, Sandy Jack. We had from the beginning decided that questions to you and Ulf Gustafsson should be at the end of this meeting, and I think that we can continue with that assumption and take the questions because we are both speaking about prehabilitation. And then I want to welcome Hanne Tønnesen, who is going to speak about alcohol cessation. And we have in Sweden new recommendations. What is risky consumptions considering general health with a lower recommendation, at least for men. We have spoken about 9-14 standard glasses per week, and binge drinking 5 or 4 standard glasses at one occasion, and now it's 4 and 3. But does this concern alcohol cessation and before surgery? That I want to know. What's new about alcohol and alcohol cessation before surgery, Hanne Tønnesen?
Thank you very much. We are trying to get to share our slides. So just a second, I hope we will manage. Can you see 1 or 2 slides now?
We see 2 slides.
Okay. We will try to change. What about now?
It's good. Now it's perfect.
Okay, great.
Thank you.
Thank you so much. I really appreciate the invitation to talk about alcohol. And we will look into the literature, what is new, and I will hopefully come back to the introduction question from Ruka. As you can see, the alcohol drinking and postoperative complications are increasing all over the world. The literature is increasing, which is really important because we need much more knowledge in this area. And just to make you remember that the ASA score, which is completely implemented in Sweden today, actually add classification of the second degree to people who are drinking socially. And that is more than low or minimal and less than alcohol dependent or abuse. What could be a little disappointing is that alcohol is not yet included in the NSQIP calculator. That is the quality improvement project for National Surgical Quality Improvement Project from the United States. They have made a calculator, but they haven't dared to add alcohol yet. However, they have made a tremendous work in including alcohol, social drinking in the ASA score. Something new is that but a few studies have been performed in digital intervention, including for alcohol. And as you can see here, that we have had 2 minor pilot studies on ICT studies on quitting drinking before liver transplantation, and 1 RCT study looking into all the 5 risk factors of prehabilitation. That is the overweight, malnutrition, alcohol, smoking, and physical inactivity. Unfortunately, there was absolutely no effect. That is probably not because that it would not help to quit all these elements, but more that even in Sweden with a very high, and in Holland with a very high IT competences in the population, it was not possible to use this digital supported tools. We have also published in the past months about 2 novel prehabilitation apps to help patients to stop drinking and smoking prior to hip and knee surgery. Also in an RCT, we used a hierarchic RCT design, so we stopped the project if the previous step did not show any effect. And we didn't find a small effect on feasibility. It means that it was possible for most of the persons involved, and we had only 8 here in this part. Most of them were able to use the app, to use the functions on the app, meaning pressing the right buttons, etc., being able to read the text on the screen, etc. And when we then looked into the validation about understanding and use and that it could be helpful, then the study stopped because there was a great variation on the measurement there. So we couldn't continue this project according to our protocol. But it was a great project to produce. It was done in Sweden, in Denmark, and in Spain. You all know the mechanisms of this, or most of you know it. A very weak immune capacity, a reduced ejection fraction from the cardiac function, disturbance in the imbalance in the coagulation, a very low level of protein ulcers and in healing after the incision, and then a very extremely high stress response to the surgical intervention. And in addition to that, a publication from Atlanta was published also in last month, showed that also the pain perception and the pain thresholds are different in patients having a risky alcohol consumption. And that means that it was more difficult to cover the pain after surgery, to take care of that in this group of patients. Furthermore, their hemodynamic changes were also of major importance. So something new has happened. We run a fast search in the literature on alcohol treatment prior to surgery and the complication rate. And actually, 16 RCTs seems to be available. However, some of them were controlled trials instead of RCTs. And some of them were protocols, and some of them were secondary analysis, etc. And we have included the 3 digital here as well. 4 of them had no alcohol treatment at all, even though that was our searching part. But if you look at the 6 ones that we found identified, then you can see that you know some of them on forehand. And they are the old one from my previous research career, my early research career. On the left side of the slide, you can see that they have had intervention, intensive intervention, or called high-intensive programs prior to surgery for 4 to 8 weeks preoperatively with a significant effect. Then if you use the same programs but add them very close to the surgery, and you can see these results are very new. And for instance, for the study by Lauritsen and her group, it included also ERAS as part of the routine of taking care of the surgical patients here. You can see that there was almost no difference, of about 10 to 12% difference between the intervention and the control group, but not significant at all. The EHOLM study from 5 years ago, which was published recently, it started 5 years ago, sorry, and that showed that was performed on ankle fracture surgery, where you cannot, of course, give the intervention prior to the trauma and then look for complications. So the intervention was added postoperatively. For Lauritsen and her group, it was added about a week prior to surgery, not sufficient time to see the effect on complications. However, there was a clear effect on quitting drinking, like in the older studies from where I was the young surgeon doing that. And then we have identified 2 new programs, one by Snowden and one by Anna Fernandez. The last one was very recent. And Snowden used a brief intervention for 4 to 6 weeks prior to surgery, but they did not aim for completely quitting of alcohol. They aimed for reduction preoperatively and found no effect at all. And Anna Fernandez and her group compared 2 different types of brief interventions, and there was no significant difference as well there. So something has happened. Just to remind you of the intensive intervention for alcohol, that is this 5 to 6 meetings over about 6 weeks and an open hotline. And these meetings include a structured patient education. And that is important because the patients who actually are aware of or become aware of the association between the high alcohol intake and the risk of complications, if they become aware of this association, then they want to participate in the studies. If they don't understand or know this association, they don't want to participate in the study. And that means that we need to do something about the health literacy for patients having a high alcohol consumption, probably similar for other risk factors, lifestyle factors. The patients got the vitamins, and we had prophylaxis against withdrawal symptoms, and then we supported their quitting alcohol in the perioperative period with disulfiram in a no dose, and then we followed up with alcohol markers to make sure that the patient-reported outcomes also fit with the alcohol markers. This is a funny study showing that all the patients from the study on ankle fracture surgery, all the patients who said no thank you to participate, they allowed us to follow them in their medical records, as well as over the databases, clinical databases afterwards. And they developed, 35% of them developed at least one complication. And the funny thing about this is that, again, when I was a very young surgeon in the last millennium, we evaluated patients drinking at least 5 standard drinks per week. 35, yeah. And they had a similar level of complications. So it seems that nothing has happened in this 20 years, even though we have changed the level of risky intake. So there seems to be a risky intake lower than we previously understood. If you want to look into a business case, it was published also last year, to show that the average cost of ankle fracture surgery, including postoperative examination in Denmark, is about 5,000 euros. However, the cost of operation for risky drinking patients, including the control afterwards, was about 3 times as high. So it means that we would have a lot to save of money if we could do some kind of intervention to avoid these complications after ankle fracture requiring surgery. Just to let you know, the last slide is how to identify the risk patient, and some very few simple questions about when did you consume alcohol at the latest occasion, and if they say I haven't been drinking for 6 weeks or 8 weeks or 4 weeks, then it's just to say that's great, please continue. And if they say that they drink within this period, then you need to know what and how much, etc. And there the timeline follow back the surgical version of it, where you ask for just 1 week and then look back and ask if you drank the same in the week before or in the latest 4 weeks. This is a simple way of doing it. So that is what I would like to let you know. To answer Roger's question, if I may do that, Roger, is it okay? Hopefully.
Okay.
It is.
Unfortunately, the quality of the sound, as far as I can hear you, it's not perfect, you could say.
You should have said that
before. Please continue.
It would have been so helpful, Roger.
Sorry?
You should have said it before, that the sound was not good.
Okay. I have difficulties to hear what you say, but I have seen your slides, and that's fortunate. And I've seen the description of your timeline follow back.
That's good.
It was fine. I could hear you, Hanne. I don't know if
that's
some
good.
more problems than we
Okay,
did.
that's good.
Once, I hope.
Yeah, I would just let you know that according to the 4 drinks or 5 drinks in one occasion actually may affect the immune capacity. However, it has not been shown to give more complications unless, of course, you drink this 4 to 5 drinks every day, having an occasion every day. Then it would, of course, impact. But otherwise, it seems to impact the part of the immune capacity. Thank you.
Okay. Katja, you have heard Hanne better than me. Obviously, it's something that isn't perfect with my computer. Do we have any questions from the chat to Hanne?
No, we don't have any questions for Hanne so far. We have one for Sandy, but I guess we'll wait with that one.
Okay. In that case, do we have Ulf Gustafsson here? Yes, he is obviously present.
Yes, I'm on the line.
Okay. In that case, very welcome, Ulf Gustafsson.
Can you see this? Or
can you present your presentation yourself?
can you see this, or can you not?
We can see it, but could you try to share it in presentation mode?
Yeah.
Thank you.
Is this okay, or?
Yes.
So I only been with you for 30 minutes, and that's always risky because I might say something controversial, or I might repeat what you already have said, but I hope for the best. So this is a colorectal surgeon's view of rehabilitation and optimization before surgery. This is a typical patient today, at least in major abdominal surgery. 85 years old, heart disease, probably heart failure, multi-medicated, at least more than 3 different medications, a cancer in the sigma with no metastasis, no symptoms, no anemia. And the question is, should you operate this patient or not? And the answer is, today, most of these patients go to surgery, depending on the surgeon's view of who are we going to operate or not. But that's risky because what does surgery mean? And the worst case scenario is death, of course, 2%. Leakage from the bubble anastomosis, 10%, and bad quality of life. And the thing is, we don't know anything. We're not sure about the quality of life of these patients because no one follows them for such a long time. And the best case scenario is, of course, that they get cured and that they are okay after 4 weeks. So if we don't operate, there might be later symptoms that makes the whole situation too late for an operation. Or the patient might be okay until death in another disease. So who is going to decide what to do with this patient? That I think is a problem today because it's a subjective assessment. Different surgeons have different views on who's going to be operated or not. And we don't have any kind of optimization before surgery, no organized optimization, and no prehabilitation. So can we reach better outcomes by using optimization or prehab before surgery? That's the big question, I would say, in the surgical community today. So I was the lead author of the ERAS guidelines in 2018. And then we concluded overall the evidence of medical optimization or different kind of optimization. And for information, which is one item within the ERAS protocol, we have low evidence. for using any kind of screening tools like NSKIP or ASA. There are a lot of screening tools. I think I counted them to 18 or 19 that you can use before surgery. But in summary, the evidence for those screening tools are low. Evidence for cardiac optimization, low. Evidence for treatment of anemia before surgery, medium. Or maybe high, but I would say medium, at least in 2018. Evidence for stop smoking before surgery, quite high evidence. And evidence for alcohol, medium or low. Evidence for preoperative nutrition, medium level of evidence. But this is not because of, we don't know for sure. It's all these subjects, all these items, it's very difficult to perform adequate or valid studies because it's, for example, for nutrition, it's very difficult. So many confounding factors. So even if we don't have the evidence, it's reasonable that if we use all these together, we should get a better outcome. One thing that we looked upon when we conducted the 2018 ERAS guidelines was prehabilitation. But there is a problem of heterogeneity because some studies means that prehabilitation is physical training before surgery. Others means that nutrition is included together with physical training. And then we have the studies that includes almost every optimization item. So you could say that those studies are more or less optimization studies rather than prehab studies. Depends on how you want to name them. So when we conducted the guidelines in 2018, what did we know? We knew that comorbidity, polypharmacy, and cognitive failure, frailty, is equal to enhanced mortality in the general population. And if you have preoperative impaired physical or functional capacity, you will have an enhanced rate of complications after major surgery. And we know that most of our patients that we do operate on have a high mean age. And we know that serious complications increases the risk for recurrent cancer. And of course, you know that if you exercise before a marathon, you will have a better performance than if you don't, of course, in the general population. So we concluded that the early studies had bad compliance and limited effect on postoperative functional capacity, and that multimodal prehab studies, that was a kind of tendency for increased functional capacity, but and some signs of decreased risk for complications. But we made a conclusion not to recommend the prehabilitation before major surgery or major colorectal surgery. So what has happened between the years 2019 until now? What is new in prehab colorectal surgery? There are some meta-analysis from Hager, Daniels, and Lambert. But what what all these studies have in common is that there is a high rate of heterogeneity, and it's very difficult to make any conclusions. And some of the meta-analysis kind of mix RCTs with observational studies, and that is always a big no-no, I think. You should, if you are going to perform a meta-analysis, you have to use randomized studies only. So some RCTs, one from Franco Carli in 2020 on 110 frail patients, a multimodal prehab, showed no difference in complications or loss. But this is, of course, an underpowered study. One interesting study from Sweden in 2021 by Onerup including 668 patients with aerobic physical exercise. However, this was a very low frequency exercise, and it was home exercise where the patients should report what they did or what they did not. And this study simply didn't show any difference, not surprisingly, between those who exercised or did not exercise. So this year we have the Prehab randomized clinical trial, and when they calculated power for this study, they should include about 714 patients, but they did stop this study beforehand. I'm not sure really why. So they included only approximately 250 patients. And in summary, they did show a decrease in respiratory complications, but in 6 minutes walk test, no difference. But the problem with this study, as in all other studies that are made, or many studies that are made within colorectal surgery and prehabilitation, they are underpowered. So now we are heading for the 2024 update of the ERAS guidelines according to grade. And we have made a literature search which make a very impressive amount of articles about prehabilitation or optimization. About 236 Medline articles, and a lot of ongoing studies, really. And I think it's interesting to look at clinicaltrials.gov, because as you can see here, there are 19 ongoing randomized studies on prehabilitation before surgery. But many of them, interestingly, have unknown results, are not published, or have been stopped for unclear reasons, which points to a very important thing about these studies, that are really heavy to conduct and to finish and to get the right amount of patients, because they are so resource demanding. Nevertheless, I and most of the ERAS community, we still believe that prehabilitation, it's reasonable that if you train before surgery, or if you optimize the patient before surgery, we should get better results. That's why we did a randomized, or we have started a randomized study at Danderyds Hospital in Stockholm, aiming for including 550 patients, and we have now included 260. And this was the kind of the basic problem, that we see our patients at the outpatient visit, and then depending on which preoperative treatment they get, they have to be all between 2 and 16 weeks before surgery, and we do absolutely nothing. And then one day before surgery, they show up at the anesthetist, and it's really too late to improve their capacity before surgery. So we wanted to change that. So we did start an optimization unit, which is daycare based, where we do all these optimization with physical training and high frequency physical exercise, optimizations of hyperglycemia and so on, smoking and alcohol stop, check of anemia, all the consultants that are necessary to optimize the patients are consulted, and of course ERAS info for all the patients. And we hope with this study, all the patients that are going for, are planned for major colorectal surgery, are going for either this care center or nothing. And the main outcome is, of course, complications. So in Karolinska Hospital, we didn't wait for the results for the Danderyd Hospital because we really think that this will make a difference. So we kind of started the first step at the Karolinska, where we measured NSKIP, and if they had a mortality risk over 5%, or if they performed on a walk test less than 0.4 meter per second, they should have a high-risk consultation. But the problem is that almost every patient did perform a walk test more than 0.4 meters per second. So this was a failure, really. So now we have started a new project where when we meet the patients at the outpatient visit, we will see if the patient is 80 years or higher, have a frailty more than 5, have a cognitive dysfunction, or have more than 3 comorbidities, or have a polypharmacy, or show sign of hiding diabetes, or simply the surgeon's intuition. We will send the patient for a high-risk evaluation made by an anesthetist or a geriatrician. And then we will decide, depending on what they say, to either optimize the patient before surgery, make an immediate surgery, or never operate the patient. So this is the plan for Karolinska. And we will start with this project within 1 month. So this is just a correctly surgeon's view of prehabilitation and optimization before surgery. Thank you.
Okay, thank you very much, Ulf Gustafsson. I think, unfortunately, you wouldn't be with us at the time when Sandy Yeck was having her speak. First, do we have any questions for Sandy Yeck or Ulf Gustafsson? Katja Stenström-Bohlin, who is reading the chat. Okay, Katja, you are muted. Okay. Okay, perhaps she can't hear me. I hope
there is a question, Roger, for me, if that's okay. I can see it. Is that okay?
Yep.
Thank you. So it's an excellent question. In one of your slides, it looks like you refer patients to a community weight management program. Is that pathway for patients that are overweight, obese? Do you recommend weight loss pre-surgery for oncology patients, or do you promote weight stability? If the intervention is weight loss, do you give specific advice on protein intake? So because we still don't really understand enough about nutrition, we do know that loss of lean body mass or muscle mass is one of the enemies of surgeons. It's always the concerns if patients are underweight, they have poor outcome from surgery. So what we do is we are more concerned about unexplained weight loss and reduced BMI. If patients have any of those self-reported symptoms on screening or continued conversations at their various clinical appointments, then we will start oral nutrition supplementation immediately for 2 weeks alone, just 2 weeks. We've spoken to the experts from the World Cancer Research Fund and within our Nutrition Biomedical Research Centre. The reason for the 2 weeks is you can do harm if you continue without monitoring. But we are not particularly concerned about overweight patients. I think that should be tackled in the rehab or recovery period, so that patients then have a longevity and have better outcomes and less chance of reoccurrence if they are not overweight. But within the preoperative assessment period of time and the wait list or preparation list, we don't think it's a good idea to encourage patients to lose weight, because they can lose the wrong weight. They can lose body lean muscle mass rather than it being fat. I hope that answers your question, and thank you.
I also think that you
have any comments?
Sorry.
Do you have any comments, Ulf?
Yeah, I think that you would increase the risk of catabolic stress or surgical stress if you do operate a catabolic patient. And if a patient have cancer, you're always in a hurry for doing surgery in time. So it's a bad idea, I think.
Thank you.
Okay, to continue the discussion, you can decide yourself what's on your interest. What I've seen is one way of assessment of physical performance is making these questions to the patient, like in the Svensk förening anestesi och intensivvård, the Swedish anesthesiologist questions, but I saw from what you explained, Sandy, was that you do cardiopulmonary exercise tests. Do you do that on all these patients?
So yes, we do 1,000 major surgical patients a year. One of the main reasons we do that, and we'll continue to do that, is that it then allows us to have the reassurance that those patients can go to a community gym. So the cost of performing cardiopulmonary exercise test certainly outweighs the cost of having in-hospital supervised training sessions, because they're really expensive. So the reassurance that the patient has had a cardiopulmonary exercise test and they're okay. Not only do we look at physical fitness, but we look at any limitations and any other optimization that we can look at. So we continue to say it's the gold standard. It won't always be the gold standard. We need to find something that we can, that's more accessible. But certainly until we know it's safe to do community and home-based training, it's the reassuring gold standard that actually makes it more cost-effective in our prehab service than having those patients in hospital.
Ulf Gustafsson, who do you do the assessment of physical performance activity among your patients?
No, I would love to have a CPT test, and I've been trying to convince the leadership in Karolinska to start with this, but it is really expensive, and we have to find a way to go through with this. I don't know how, because I think it's the only way to make a fair assessment of a patient's capacity.
It will be strongly supported, should we say, and recommended in the new guidelines. And we're hoping that NICE will endorse those guidelines. So we're revisiting the Macmillan and IHR Royal College of Anaesthetists guidelines or guidance that was 2019 to really shake it up, because what we're seeing is, well, we understand it a lot better now, and we actually thought we knew more then, and we know less now, but that's good because it opens the conversation of actually what should we be doing, how can we do this, and what do patients want. I think we kind of haven't really considered what patients want as well. But yeah, I mean, it hopefully will support the case, particularly if you can do hybrid of, home-based. So our SafeFit trial, we did weighted skipping ropes, we did cancer beans, we did all sorts of things that improve patients' frailty levels, etc., etc. It's very hard to have recorded any of those hard outcomes because it was during COVID. And the reason why our Westfit trial was paused and then we haven't reopened it is paused because of COVID, but we haven't reopened it because we may potentially have a positive outcome, and it felt it was unethical to continue. And I think that's the problem with all of our trials now. So that I think that's the reason why the studies, particularly the NIHR studies, because they saw how difficult it was to be able to then, with all the elective recovery, to have a really good planned surgical pathway that we could integrate prehab. So they thought it was too high risk to continue the trial, as in there would be a failure from the UK perspective anyway. I hope that answers some of your questions, Ulf, and why have we stopped? Either we're told to, or we felt that it wasn't the right thing to do to continue. I mean, I agree with everything that Hannah and the presentation before with your two amazing students have said, particularly around ERAS. It's so important we get the support from ERAS, and I know I have very many conversations with Ollie Lindquist about all of this, and it's great to hear that even though the evidence isn't there, you seem to think it's the right thing to do. But I agree with everything that you said, the presentation on the lack of evidence, and how we support, you know, what we do to drive this forward as consensus, which I think is really important. I'm sure Hannah might want to comment at some point.
Thank you very much. And I'm happy that we can agree on this. I think it's very much like a Tour de France, a bicycle you use for Tour de France. You want to improve it and improve it and improve it. And I think we have to do that until we get the intervention that works. And then afterwards, we might reduce it until we get the minor intervention that would work. But I think we have to continue doing research in this way forward. I can let you know that we are, together with our two beautiful PhD students here, are performing a Strong for Surgery, Strong for Life study where we also look into overweight. Of course, we take very much care about the patients because it's a failure if they lose muscle weight, etc. But the fat tissue, as we previously expected to be more like neutral tissue that was in our way when we did surgery, we know today that it's actually a very immune active tissue. And that means that if we can reduce that, we can also change the immune capacity just by reducing it. We know that from rheumatology, where they measure and recommend people to reduce their overweight. And the good thing is that you don't need to be normal weight. As long as you just don't increase anymore, then your immune capacity, the defect in your immune capacity will stop. And if you reduce just a little, then the immune capacity will like cure itself. It's really, really interesting. So we are looking into that, both for the cancer surgery, which Line is part of the Cancer Strong study, and also the hernia repair, which is minor surgery, but where we have a lot of overweight patients included. So hopefully we will come up with some new results. So that would be really exciting.
That's really important, Hannah, really, really important. I think it kind of backs up what I said. We think we know, or we thought we knew what we were doing, but actually it's back to the mechanisms. We need to understand the physiology, the phenotype of the patient, as well as the tumor. And hopefully we and others are going to do that. We've kind of taken a step backwards. I think there'll be less effectiveness trials because, as Ulf articulated very well. These are hard trials. These are hard trials to be able to deliver. You can put your life on hold and don't have holidays because you're the chief investigator and you're concerned about everything going wrong, and call your trial safe bit when it's virtual, and that was high risk, but it was meant to be all about COVID. So I completely agree, they're hard. You've got to really want to do this, and probably for the right reasons, not a paper, because that certainly doesn't get me out of bed in the morning. It's for this to be really good standard care that improves patient care. But I do wonder whether we need to pull together we're missing out on these pockets of people that are doing fantastic stuff, and I don't know how we can pull this together, because I know Canada are doing stuff in the Netherlands, and but it's how we bring all this expertise and insightful thinking around the problems and how we approach it. Because it's not all about an academic or a clinical approach, it's somewhere in between. So it's informed, and it's evidence-based, but it's also lived experience. And I think that's probably what I present these days. I've been there, done it, and it's hard. It took us a long time, 15 years, to get our service funded as a recurrently funded service by NHS. And it took a long time to set it up, and we thought we knew how to do this. So I think it should just perhaps be noteworthy to everyone. Don't give up, because it's hard, and don't think that you're failing because you can't get your business case agreed, because we've been there and done that, and persistence seemed to work. But with some of the mechanism and the physiology that we can go back to show that this is a physiological phenomenon, rather than it just being patients feel a bit better and then they get out of hospital earlier, then I think it's so important.
Absolutely. And we are not able to do all the pathophysiological examinations as we want to do, but we are able to build up a huge bio database with a lot of tissue tests and things like that. Hopefully we can maybe do this analysis together if we get sufficient ideas on how it can be evaluated afterwards. But that could be a good idea, and I think definitely we should work together in this area, because there are not that many of us. But
no.
But there are not that many. So I think maybe we should get some kind of a session on IRASH or others who are in another conference where they're really interested in improving the outcome for patients in relation to surgery. It could be a good idea, instead of splitting us up, saying, oh, but we're looking at colorectal cancer, or we're looking at gastric cancer, so we have to go to another conference. And hernia repair is a third type of conference. So it could be a really good idea, I think, to let us go together to put in a suggestion for a session or two at the IRASH, the next meeting there. What do you think about that, Ulf? Would that fit into your approach?
Yeah, it would definitely fit in our approach. I think there's a lot of exciting things now. For example, I think England is in the front line. I don't know if you know Yugdep and the POPs trials, and she is such a good performer, or she presents this area of field so good, and I think she will make this area popular among geriatricians, and that's really important, I think, to get a whole community of doctors in this thinking. And I don't know if she's managed to do that in the whole England, but still in London, I think, at least in London.
Oh yeah, only in London, I think, at the moment.
Yeah.
The problem with, we'd love geriatrician input, but they're so expensive. So we couldn't get a comprehensive geriatrician assessment, which is what I always wanted. We couldn't get that within our business case because they said it's too expensive. And there aren't enough, it's like dietitians and psychologists, they're just, the workforce isn't there. So we have to do what we can do. Yeah, but I know
because it's really difficult to get surgeons interested of this, of prehabilitation optimization. It's really difficult. So we should have kind of prehab centers that take care of all these preparations.
Absolutely, you're right. Getting buy-in from surgeons isn't easy, but having a surgeon who did his PhD in this with me 10 years ago has always helped. And with Westfit, we had Westfit Envy, so all the surgeons we had to put head and neck in there in the end, because they were like, our patients really need this. It's like, well, it's not really what we're supposed to be doing. So yes, but the surgeons, like the whole multidisciplinary team, are so important, but the surgeons do really get this when you know, they get to understand the whole concept of your patient is so important to you. You think about your patient probably more than most people do. You know, we talk to pharma and they're really interested in prehab because they realize that drugs are only as good as the patient receiving them. So I think it's a real paradigm shift in thinking more about the person than just what you're doing to them. And that's kind of what we're hoping to promote and support.
Absolutely. I think our main person today, Olsson, is one of the surgeons really, really interested in this area, together with Katja Stenström-Bohlin as well. I mean, I know you are from obstetric and gynecology, but that is also surgery.
At the moment I'm more of a cancer surgeon, so I totally agree with everything. It's so important, and I found all of your studies very, very interesting, especially Sandy. I haven't heard so much about your studies before, and it was really interesting to hear. And
thank you.
And I understand, but what I understood, you have implemented a lot of your results in your practice, or did I misunderstand?
We have. There are patches of services in the UK, none of which are substantively funded. So we were the first thing to get NHS to fund it, being Cancer Alliances and other funding. This new contract is a game changer because the trusts and our integrated care systems and boards will be fined if they don't adhere, but then they could always pay the fine because it's probably cheaper than setting up a prehab service. So I remain, I don't know what the word is, not pessimistic, but realistic about whether it's going to make a big difference or not. I think the whole gynecology world is really lacking in us being able to deliver prehab. Those patients go through a torturous cancer therapy regime, and it's really difficult to be able to get them within our perioperative medicine service. So we're hoping they will be included.
I'm sorry to hear that. I hope you can influence them in a good way.
We supported mainly gynae and breast for SafeFit, and that was when we found out, wow, they suffer. Their regimes are really tough.
Yeah.
But it's not, do they say it's major surgery? Well, it is major.
Yeah, big surgery, yeah.
So we're trying to promote that as well.
Good.
We are coming closer to an end. I think last year's meeting was a take-home message was that the time from diagnosis to treatment to surgery shouldn't be just a waiting time, but a time for preparation. Do you think that is something that we can have as a take-home message this time? And should we include then a prehab center at every perhaps central hospital in Sweden. What would you like to see, Ulf Gustafsson?
Yeah, definitely. I would like to see a prehab center at every major hospital. And I think we will reach there, but it will take time.
Yeah.
I hope that we can include prehabilitation in this the 2024 ERAS guidelines. I hope the evidence are there.
Fingers crossed. And we shouldn't need to cancel, or we shouldn't need to delay surgery. We just need to get our pathways sorted out. I know there's controversy around that, but I think the preparation lists are the key thing.
Absolutely. And maybe
any last words then, Hanne Tunnesen?
Yes. Sorry, thank you. I think we should also think about making the prehabilitation, the broad prehabilitation programs in a primary care. Of course, we should need to do it inside the hospitals, at least as long as we do the huge randomized controlled trials, etc. But afterwards, it should be able to like move it from the hospital out to the primary care, because that would be much cheaper and probably also much better. And then we could collect it as a prehab center there instead of having it in the hospital. But that is a dream. Let us find the evidence first.
we can all dream. I think if prehab does get included in the new ERAS guidelines, then that will be phenomenal. I know there's lots of people pushing for it, so fingers crossed.
It also gives the possibility to start as early as possible, and that must be important.
Yeah, we need to stop being so paternalistic and saying you can't talk to a patient about prehab until they've got a cancer diagnosis, because that's just not the right thing for the patient. Okay. So we'll end on that. It's all about the patient, hey?
And then I want to thank you, all of you that has contributed to this meeting. And Elinor, can you show the finish line there? The time to surgery should be a time for preparation and not a waiting time. Thank you.
Thank you so much.